So today I'm going to talk about how to assess the effectiveness of non-pharmaceutical interventions during the early stage of COVID-19. Sorry. Yeah, so this work is done with in collaboration with Pauline, who's everyone knows Pauline probably, and Laura, who's a statistician at University of Victoria, and our master student Tanya Philipson, and our PhD student Manting Wang. So I'm going to present two parts. Each part, the first part is done by Tanya, the second part is done by Manting. So we're going to have a quick introduction about what challenges that we face to assess the disease intervention measures during the early stage of an epidemic. We'll use COVID-19 as an example, and then we're going to look at two special cases. One is to disentangle the control measures that targeted different age groups in major cities in Canada. And then the second project is about evaluating contact tracing, and we apply this method to Ontario in the very early stage of the pandemic. So here is a plot of the COVID-19 cases in two age groups. The red is the adults, that means 20 years and older, and the blue are the younger age group, which is from 0 to 19. In three major cities of Canada. This is Calgary, this is Greater Toronto area, this is Greater Vancouver area. So if we, if we just concentrate on the first panel, so the cases in two age groups are plotted together in the same scale, and you can see that the red dots and blue dots, they sort of form two curves that are parallel to each other. And please keep in mind that the vertical scale is plotted in the log scale, the horizontal is linear. So that basically means if they're parallel, that basically means that the ratio is roughly a constant. And you can see that in most of these periods, the curves are actually roughly straight lines. And somewhere, like for example, here you think that it's, well, a straight line here, maybe a straight line here, but it's actually certainly changes. And as we can see that actually the slope of the straight line changes from time to time quite a bit. And we know that it's from control measures. Turns out that Tanya, our master student, has gone through this trouble of going through the big spreadsheet that's maintained by PHAC about all the control measures implemented in each province in Canada. And she identified the periods where the control measures change and had a rough estimate about the impact or the strength of the control measures. And then we can look at the second and third row where the color in the background shows you the change in the strength of control measures. The second row is the adult control measures. The third row is control measures that's mostly related to schools, for example, holidays, school closure, etc., or mixed opening. And you can see that, for example, in the periods where this growth rate changes, it's mostly driven by gradual increase of the strength of the control measures. And we can see that, for example, when relaxation happens in the adults, that typically kickstart the growth of the epidemic in almost all of these places. Once we have a relaxation, the curve starts to grow. So it's kind of interesting to see what kickstart. It's not really school opening. It's actually what mostly changes in the adults. But then after studying all these, we realized that the case counts mostly change exponentially in each intervention period. Like if the intervention changes, the growth rate changes, but it's still roughly exponential in the almost whole first year of the pandemic. And the adults and younger age groups have similar exponential growth rates, or curves in log scales or parallel. That basically tells us that their disease dynamics are closely coupled. So if we do anything in the adults, you would see changes in the kids. If you close school or school opens, any implementation of control measures in the kids, you would see cases in adults change as well. So that's why these two curves are roughly almost kept parallel to each other. And if you are interested in ODE models, then you'll realize in the exponential growth stage, if you linearize it, then the disease epidemics just converges to exponential growth with the rate of the dominant eigenvalue of the linear system, and also the ratios of the cases in each categories or age groups are determined by the associated eigenvector. So that if we just look at these, the first stage, what we can really estimate is just the growth rate. And another one is the ratio between the cases in different age groups. So we can't estimate too many disease parameters at all. And then how do we decouple the effects of different control measures? For example, school closures, school opens. There are others like social distancing, wearing masks, contact tracing. They all contribute to the change in the growth rate. But we only observe the specific growth rate. So how can we decouple the effects of different control measures? Well, that determined on the problem that we that depends on the problem that we look at. So we look at two specific examples. One is to understand the age-specific intervention measures like school closure or closing restaurants or bars, which typically mostly affect adults, while school closures, school holidays, school opening, they would mostly affect kids. So can we decouple these age-specific control measures? How do we do that? And specifically, we are more interested in school closures and school openings, or the effect of strengthening control measures in the kids. And some studies have shown that strengthening interventions for adults may have similar effects as school closures. And we are specifically interested in how generic is this statement. Does it depend, is it general for all regions, or does it depend on different implementation times? Does it depend on other control measures, or does it depend on the kids and adults have the same or different susceptibility, etc.? So these are the questions that we mostly want to answer in the first part of this talk. So some literature review, it has been shown that school closures may not be effective at reducing cases if, for example, the kids or youth susceptibility or infection is different, is actually lower than the adults, then preventing case infection is not as effective as preventing the adult infection. Or it's also possible that school closure isn't effective if community transmission is high, right? So if the cases is already up, then closing down schools may have a smaller effect, or may not have enough effect to control the disease. And if the response is delayed, it's similar when the case count is high, school closure may not be as effective. it has been found that in Netherlands, reducing school-associated contacts would have limited impact on R. So that again strengthens the fact that maybe school closure isn't as effective, but it could have an effect when the R naught is when the R control reproduction number is close to 1. Then if you close down schools, it definitely is going to push it below 1. And there are other studies showing that, for example, in Toronto, slight increase in adult control rates following school openings in the fall of 2020, resulting in significant more cases compared with schools remaining closed. So that just shows that adult control measures has a larger effect in the cases than school closures. So to answer our questions, whether these results are generic, we just use as simple a model as we can use, because as we said, this is the exponential growth stage. We don't have many information. If just from the case counts, we only have the exponential growth rate. We can't estimate too many parameters. So we want to use a simple model. So we start with the SEIR model, ignore the asymptomatic transmissions. Whether that's good or not, it's a different story, but we just want to reduce the number of parameters. But we do want to keep the E class in it because we know COVID-19 has a long incubation period, which greatly affects the growth rate. So we consider two age groups, the adults, which is 20 and older, 20 years and older, and the kids were from 0 to 19. This is just the standard two age group SEIR model, where there is a mixing matrix or contact matrix C, which is 2 by 2. We have adapted the matrix from the literature to these two age groups. And the beta is the probability of transmission per contact that is multiplied with the contact rate C. And we have the susceptibility psi in each age group, and psi adults would just be 1. And psi of the kids is set to 0.5 from literature. And what we're more interested in is the epsilons. They're the effect of control measures on the transmission in each different age groups. So we would have epsilon A for adult control measures, epsilon K for kids control measures, and if epsilon equals 0, that completely prevents transmission, and if epsilon equals 1, then there is no control measure. So epsilon is somewhere between 0 and 1. And there are other, like the latent period is 1 over delta, and the rate of diagnosis is 1 over gamma. This diagnosis removes the individuals from the I class, and this is the new cases data that we're going to match. So that's our model. We fit to the data that I just showed earlier as using the Poisson regression. It's basically maximum likelihood estimation using a Poisson likelihood. So we have fixed the disease parameters like the susceptibility and the latent period 1 over delta and the diagnosis rate gamma from literature. What we want to estimate is beta, the probability of transmission per contact, epsilons, they're the strength of the control measures. Now, but there are 3 parameters, and as we said, we only have 2 main quantities, the exponential growth rate and the ratio of the cases. How can we, between adults and kids, how do we determine 3 parameters from 2 quantities? Well, it turns out that from the initial stage, before the community control measures were implemented, the situation is much simpler. Because no adult control measures was put in place in that period, the epsilon A would be 1. And for kids, either the school in some regions is closed So there would be no kids contacts, epsilon k would be 0, or the school would be open and there would be no, the epsilon k would be 1. So the only thing that we don't know in the first period is just this transmission probability beta. So we can just fit beta from the period before significant community interventions was implemented. So that was the period that's listed here in the 3 areas. And here, the school in the first period is open in Calgary and Toronto and closed afterwards. And Greater Vancouver area in this period of the first half of March, the school is always open. So with this information, we can estimate the transmission rate beta in each, the transmission probability in each period. So once we determine beta, it's the same transmission probability, it's without control measures. So that's our baseline transmission probability. So what we really want to know is how interventions changes this probability, and that's the epsilon A's and epsilon K's. So for each subsequent period, we're just fitting our model to each period with the beta fixed from this table and with epsilon A and epsilon K's fitted from data. And for each, it's still the same as EIR model, and the epsilon A and epsilon K's, you can think it's as step functions. So the end state of the state variables as EI in each period is the initial condition for the next period. So here is our fitting result. As you can see, it roughly matches what the behavior of the strength of the control measures. As control measures get strengthened, the epsilon A, for example, gets smaller and smaller. There's also, we can see the effect of holiday seasons, like here is the Labor Day, and here is the Christmas. Here is, it's in May, I guess. So you can see that there's these little changes that's caused by different control measures. Relaxation causes to increase. A holiday makes the mixing much more and makes the intervention less effective, etc. So we can actually effectively estimate or distinguish the age-specific interventions and their effects in each period. So we can run some scenario analysis. What ifs? Now, what if the schools were closed in fall? How would it turn out? So here is the dots are the real data. The blue curve is our best fit of the model, which is what we believe is the reality. And the school closure is this blue curve. We just say that it doesn't completely prevent kids mixing, but the kids mixing was reduced by 90%. So it's, as you can see, that closing down schools in the fall, in September, has some small effect on the number of cases in the adults. Also, in the kids, the effect isn't very strong either. And that's true for all 3 places, where Vancouver seems has a slightly larger effect. However, if we enhance the adult control measures while keep the school open, just by increase the adult control measures by 20%, and that's the red curve. As you can see, reducing the adult control measures by 20% has a much larger effect than closing down the schools. And that's true for all provinces, for all cities. And what if we include both the control measures and the closing down schools? That's the gray curve. That has some effect, but not very large. So as we can see that This indeed demonstrates that it doesn't, for the fall 2020, the effect of a slightly stronger control measures in the adults can be a substitute for school closure in the school. It doesn't depend on the regions. What if in the spring, the school was in the spring of 2020, in the beginning of the epidemic, what if the schools were open rather than closed? That, interestingly, has a much larger effect. In Calgary, as you can see, the dots are still the cases. The blue curve down here is our best estimate. But if the schools were open, this blue curve in Calgary is very high. It brings up the cases almost a magnitude higher. And Greater Vancouver also has a relatively large effect. It's probably just more than tripled the case counts. But in Greater Toronto area, the effect isn't too large. And what if the school is open, but we strengthen the adult control measures in the fall rather than in the spring? So we can see, starting from the spring, the case counts in Calgary is still high, but once in the fall, in September, we start to implement adult control measures, and that brings down the cases. So even though the schools opening in spring could be quite devastating in some areas like Calgary and Greater Vancouver, but implementing fall control measures can still bring the cases down, even if we keep the school open. But in Toronto, the effect is much smaller. We think that this might be because the transmission rates in the early stage in Calgary was much higher than in Vancouver and Toronto. So we're not quite sure why Greater Vancouver area has a larger effect for school openings in the spring. But for Calgary, it might just be because initially the effectiveness of the adult control measures wasn't quite effective. And we have seen that adult control measures has a larger effect. So at last, what if the kids have the same susceptibility as adults, and what if the schools were closed at fall? As you can see that if the kids have equal susceptibility as adults, the case counts, that's a blue curve, would be much higher, but it would have a much larger effect in Vancouver. We're not quite sure what causes this, but in other places, overall, the case counts, even in the adults, would be much higher. In the kids, it would be even higher. So it has a big effect, but it's still the same. If we just close down schools, we have some effect, but if we strengthen the adult control measures, we have a much stronger effect. So it's always good to strengthen the adult control measures. And that's true for COVID, but for example, for future influenza pandemics, it would be really similar because the susceptibility in the kids are probably the same or slightly even larger than the adult susceptibility. So what we can do in the future, we can look at, well, many research groups have looked at more finer age groups, and many cases in the adult groups are from long-term care homes, and these cases are not well mixed with the rest of the population. We want to understand whether the adult cases have the mixing, assuming that the adult were well mixed, is not a good assumption. And what about asymptomatic transmissions, for example? And another thing that really limits all of these studies is just multiplying a constant to the transmission probability. But actually, many control measures like school closures and school reopens not only changes transmission probability, but it also changes the mixing patterns between adults and kids. So the whole the mixing matrix should change rather than just the transmission probability change. And how do we properly incorporate this needs to be well understood. So another part is actually even harder because we want to estimate the effectiveness of control contact tracing during the very early stage of the pandemic. And contact tracing is just the control measure where we trace the new cases and find all their contacts and try to isolate their contacts or quarantine their contacts. That prevents further transmission of the infected contacts, and thus reduce R0. For example, if A is infected and diagnosed, we immediately look for all the neighbors of A and try to isolate them. Some of them are already infectious. Once B is isolated, it stops B from further transmitting. Some of them are not infectious yet, so we quarantine them, and that stops them from being transmitting at all. And it's possible that we miss some of the contacts, and this is a leak of the contact tracing. So the key parameter here is just what's the fraction of the contacts we can track. And that's what we call the coverage probability. And it's a quite effective control measures. For example, in China, in the early stage, it's the very strong control measure that actually controlled the epidemic in 2020. City lockdowns are only implemented in Wuhan, but most other places have this very strong control measure, contact tracing measures implemented. Well, in North America, we have contact tracing, but we don't have very strong contact tracing. So that can make a big difference. And we want to estimate things like that, how effective it is in North America, in Canada, for control measures, for contact tracing. And it's a hard problem because contact tracing is capacity limited. You can't do effective contact tracing when there are millions or thousands of cases per day. And but at the early stage, again, we really only have this exponential growth rate, but we also have contact tracing. We have social distancing, we have mask wearing, etc. We have a lot of other control measures that they all change the growth rate, but we only have the growth rate. So how can we distinguish different effects from different control measures in this very early exponential growth stage? There are many models. For example, there's the first compartmental model for contact tracing is actually introduced by Lipschitz group to study SARS. There are also for COVID-19, there's Jian Hong's group, etc., have done this contact tracing using similar framework. They just assume a constant fraction of the cases are contact traced. However, this fraction is actually a dynamic variable. It depends on many disease parameters, such as the transmission rate. So if you put in other control measures like social distancing that changes the transmission rate, that also changes this fraction. So it's still hard to actually decouple the effect of other control measures and contact tracing. A network model is very helpful to model contact tracing just because it keeps tracks of contacts, while the standard compartmental models don't keep track of contacts. So the first network contact tracing model is actually developed before the compartmental model was done in 2002. But these models need network information, which is generally not available at the beginning of a pandemic. And it's still after COVID-19, we have more information about how population are mixed, how the contact network should look like. But we still, for most places, we still don't have a good information for the contact network. There's another class called branching process, which is the stochastic model. It has been applied to study COVID-19, and it's very suitable to compute the effect on the basic reproduction number, but it's not easy to calibrate these stochastic process models to the real epidemic curves. So we're going to base our study on a research toy model that we developed earlier, that it's a SIR model. We're going to extend the model, our framework, to include the latent periods and asymptomatic transmissions. This framework is based on a pair dynamics, which we're going to introduce in a moment. And how do we, so we're assuming a randomly mixed population, but how do pairs come in this randomly mixed population? If we just look at a toy model where the disease transmits in this randomly mixed population, we have an index case, it transmits to a few neighbors and a few other neighbors. Then we have a tree of transmission, and these trees, the edges just label who infected who. And so it's a transmission tree, and contact tracing actually just operates on this transmission tree. If one node is identified, then it follows the tree of contacts to look at all its other neighbors. So we're going to just build up this tree of transmission from the randomly mixed disease, from the disease transmission in the randomly mixed population. So this is just the standard SEIR model, but because of contact tracing, we need to keep track of quarantined individuals for those who were in the latent stage, and those who were tested positive individuals. These individuals, after some certain delay of 1/θ, would trigger contact tracing, and we track to their neighbors. And they're moved into a traced class, so they won't trace contact tracing again. Now, how do we actually estimate the effect of contact tracing? If we follow who infected who, and if an individual is infected, his infectious, his infector is diagnosed, then this diagnosed individual would trigger contact tracing and find the contact of I. And it's also possible that I is still infectious, but one of his secondary infection is diagnosed. The contact tracing would go backward and find this I. So these arrows, or this square brackets with the two nodes and the arrows in between, they label the pairs, who infected who. The arrow notes the direction of transmission in this pair, and the two letters denotes the state, infection state of the two nodes in the pair. So that's the general form of the pairs. So infection, the I contacting S would cause the S become entering the latent class E. So then we form an EI pair. The I is the infector, E is the infectee, and then each individual can just progress in disease with disease progression independently. For example, E could become I, so then the EI pair become II pair, and the I could become diagnosed, so the EI pair becomes ET, and then this T would trigger contact tracing, etc. And when the E is contact traced, they would be quarantined. So this is the minimal edge pair dynamic pairs that we need to track in order to close the previous population model, where we have the edge here for diagnosis and here for quarantine. But then you realize that the edge dynamics also depends on the neighbors of these two nodes. So you would have to consider 3-node interactions, and to understand 3-node interactions, you need 4-node interactions, etc. So it's an infinite chain. Somewhere we want to close the model without going in along this infinite chain. So we use pairs to approximate the triples, and this is called the triple closure. It's a standard practice in all network models. So we just use the simplest triple closure scheme from the network model, and it gives us this set of huge equations. And this ratio comes from triple closure. So what if we want to add asymptomatic transmissions in? We can do similar things. The E, once they become infectious, a fraction of them go to asymptomatic cases, a fraction of them go to symptomatic infectious populations. And then we just build up the SEAIR model as before. The only difference is we want to track the pairs. And the pair dynamics, this is the pairs that we must track for the SEAIR model in order to close it. So I'm not going into too much details of this flow chart. If you're interested, you can always just look at the slides or just discuss with us after the talk. But how well is our model? Well, we just develop a different agent-based simulations without our ODE models in mind, just set up the contact tracing process of the SEAIR disease progression with contact tracing. We run 100 simulations, and the mean is the blue curve, and the two dashed lines are the 95% range of the simulations, and the red curve is our ODE simulations. As you can see, they agree very well, and especially in the exponential growth stage, they're basically the same. They have the same exponential growth rate. That tells us if we want to use our contact tracing model to study the initial stage, that will be good. It's a good model. So here are the model parameters. It has 3 classes. The disease-related parameters are here. The transmission-related parameters are here, the transmission rate and the voluntary testing rate. So we assume that infectious symptomatic individuals would go to test at a rate tau I. Asymptomatic individuals can also go to test at a rate tau A, but actually for the very early stage in all these 3 different provinces, they don't allow asymptomatic transmission testing. So tau A would be effectively 0 in the early stage. So that simplifies our model. And what's more interesting is the contact tracing related parameter. One is P, it's the fraction of the neighbors that we can catch by contact tracing, or contacts, the fraction of contacts we can catch by contact tracing. And 1 over theta is the delay between being diagnosed to trigger contact tracing. So these 2 parameters are what we want to evaluate or estimate. So we know that case counts are not sufficient enough because we have change in the transmission rate from other control measures and contact tracing. They both change the growth rate. So we need other data. So the question is, what data do we need? So we go through this simulation study, use, new cases. It's a, we look at new cases, but new cases have, the cases could be identified through voluntary testing or through contact tracing. So we need some kind of information on contact tracing in the data. So that would be this part, but they're complementary. You really just need to provide one. And for the contact traced cases, do we want to know whether the case when they're identified is already in the infection stage, so they're isolated, or they were in the asymptomatic stage, so they were quarantined. They are, again, complementary. They sum up to the detected cases by contact tracing. So we look at 4 possible data set. We're going to need new case counts. We're going to need either voluntary testing or detected by contact tracing. We need some information about contact tracing. We need, the next question is, do we need to know the number of cases who were quarantined? And other is symptom onset data. We can collect. Do we need it? So basically, we divide the data set into 4. They all contain new cases with contact tracing, and a number of cases detected by contact tracing, but we want to understand whether we need to include either of these 2 data sets. So we generate our data with agent-based simulations, and we fit our model to these 4 data sets. And here's one example of the generated data of the 4 data sets, and we fit our model using MCMC with Poisson likelihood. Many of the parameters are assumed to be known, like the relationship between the transmission rate between asymptomatic and the symptomatic classes, the fraction of asymptomatic individuals, latent and infectious period are all assumed to be given. We want to fit, well, there are 3 different periods where the transmission rate changed to simulate to simulate social distancing and other control measures. So we need to fit the 3 transmission rate in these 3 periods and the testing rate tau I and the contact tracing parameter, which here is the result. We fit it to both models of SEIR and AIR model. And you can see that so the 2 columns, or the 2 cases where we include or not include asymptomatic symptom onset data, the 2 rows or include or not include the quarantined cases. As you can see, without the symptom onset data, we can't estimate at all, but we have to provide the tau I. It should just be a single column. It was a typo here. We should include tau I, so that if we give tau I without any symptomatic onset data, we can fit all these parameters. But if we include symptom onset data, we can estimate tau I. And you can see that the estimate of the SEIR model with asymptomatic, without asymptomatic transmission underestimates the transmission rate and etc. But the tau I's are roughly the same. So symptom onset data is important if you don't know the testing rate. However, quarantine and not quarantine, with or without the quarantine cases, it really just narrows the quarantine cases, narrows the confidence interval a little bit, but there's no big difference. The estimates are roughly the same with a narrower confidence interval. So it's not important to include the quarantined cases in the data. So that's great news, because in Toronto, we do have new cases, we do have symptom onset, we do have close contacts, which we use it as the proxy for contact tracing. So these are the 3 data sets we're going to fit to our model. Here are the fitted results. As you can see consistently, as the EIR model underestimates almost all parameters. Well, what we found is that it's about 30% of the contacts are close contacts that we can trace by contact tracing, using the contact tracing methods in North America, where we just follow close contacts. And that's interesting because there are other studies found 30% of close contacts. We have a study looking at the influenza transmissions in households in Shanghai, and we found about 30% of the transmissions are close contacts, through close contacts, and 70% are through community or school transmissions or workplace transmissions. We can actually fit the diagnosis rate in each period, and we can see that as control measures were put in, the testing rate becomes larger. So we can't just, so the other control measures like social distancing, testing policy change, not only changes transmission rate, but it also changes the testing rate. For example, the delay between the diagnosis and triggering contact tracing is roughly 1 day, and it's roughly the same for the 2 models. What's more interesting is that if we use the latent period of 1/0.27 from the literature, we don't get as better fit. But if we fit the parameter values of the rate of showing symptom, the sigma, or 1/sigma is the latent period, we get a larger value for that, or shorter latent period. I think there are multiple reasons. It could be that the 0.27 didn't include the pre-symptomatic stage, well, included the pre-symptomatic stage, while our sigma exclude the pre-symptomatic stage. It's another possibility that we're just using exponential distributions, and that's assumed implicitly by the ODE model. But actually, the real distributions are not exponential, so that could change our parameter estimation. So how well does our model fit? So here's example, it fits really well, and these little increases are actually caused by the change in the testing policy. So the tau I actually changed in these two periods. It fitted very well. And what if we change the contact tracing rate, for example, the coverage probability? If without coverage, without contact tracing, that's the green curve. As you can see, this is RC, control reproduction number, is mostly changed by beta and tau I. While contact tracing reduce the RC, what we believe the estimated transmission rate is the red curve, but if we double the coverage, it's this curve. And then if we triple the coverage so that we cover most of them, then we can actually even control the epidemic in the first period. But because of the asymptomatic cases, the symptomatic cases is only about 30% of all the cases. So for North America, it's difficult to, using the contact tracing method that we're using, it's difficult to find the asymptomatic cases through contact tracing. So that limits the P. So P is really just 30%. But if we adapt other methods that can help us identify the asymptomatic cases, or even the community transmissions, for example, we're not tracing contacts. If I'm sick, I go to a restaurant, the contacts in restaurants were not traced. But if we trace these and maybe trace to grocery stores, that become crazy, like for example, the strong the contact tracing schemes in China in the early 2020 included all these. They just saw, say, a patient, they don't disclose who the patient is, go to which stores on which day, so that if you visited these stores, please isolate yourself. And that would certainly help to increase the P, and it would greatly help the effectiveness of contact tracing. On the other hand, the delay has between contact tracing and the diagnosis has some effect, but it's not very large. The current delay is just 1 day, that's the red curve. But if we make it 2 days, you can see the curve increase a little bit. It becomes higher, but not too high. But then if we make it half of a day or even just 3 hours, it makes no big difference. And this is probably because the incubation period for COVID is quite long. So that makes the results less sensitive on the delay. And another thing I want to talk about is the number of cases, the prevalence. As you can see, even though the reduction in the reproduction number is not too big, the reduction in the cases is quite big. It's roughly reduced more than half of the cases. On the other hand, if we use SEIR model, it gives you a similar outcome, except that it underestimates the prevalence. That's all I want to talk about. And specifically for contact tracing, it's important to include new cases. It's important to include symptom onsets if you don't know the testing rate. However, if you know the testing rate, you don't need symptom onsets. It's not important to include how many cases were identified were quarantined before or not. It improves your accuracy, but it's not necessary. We know that SEIR models without asymptomatic transmission would slightly underestimate the parameter values, and it significantly underestimates the prevalence in the population. So with strong contact tracing, it's possible, it's easier to control the disease, but without contact tracing, it would be much harder for Ontario to level the epidemic curve in the early stage. All right, everyone, thank you. That's all I want to talk about today.